Tuberculosis. You've definitely heard the name, right? But what are we really talking about? Well, today, we're going to cut through all the noise and give you a super clear, high-yield breakdown of one of the oldest, most stubborn infectious diseases humanity has ever faced.
I mean, for thousands of years, this thing has been like a shadow, just following us around. It is ancient, it's incredibly resilient, and even with all our amazing medical advances, it's still a really tough enemy. So let's pull back the curtain and get a good look at what we're really up against here.
All right, first things first. You can't defeat an enemy until you know it, right? So, what is tuberculosis exactly?
Okay, so at its heart, pulmonary tuberculosis, we'll just call it PTB, is a chronic infection. This isn't some quick cold that's over in a week. No, this is a slow, relentless attack on the lungs. And it's all caused by a bacterium called Mycobacterium tuberculosis. This attack leads to a really classic set of symptoms you've got to watch out for. A cough that just won't go away, weight loss you can't explain, and those awful, drenching night sweats. Now, let's zoom in on the culprit itself. This bacterium, think of it as a master of survival. Seriously. It grows super slowly, which is kind of clever because it lets it fly under the radar of your immune system. It's also incredibly tough. It can resist drying out and disinfectants that would totally wipe out other germs. And here's a key detail. It's what we call an acid-fast bacillus, or AFB. Basically, it has this waxy coat that makes it really hard to stain in the lab, which is a huge clue when we're trying to identify it. Okay, so we've profiled the enemy, but how does it get around? And who's most likely to get sick? That's the next big piece of this puzzle. How it spreads is actually deceptively simple, but also incredibly effective. It's airborne. That's it. When someone with active TB coughs, sneezes, or even just talks, they're releasing these tiny microscopic droplets packed with bacteria. All it takes for someone else to breathe them in, and the infection can start. It's totally silent, completely invisible. So who's most at risk here? Well, the common thread is pretty clear: a weakened immune system. Think about it. Conditions like HIV, malnutrition, even diabetes, they all compromise the body's natural defenses. And then you add in lifestyle factors like smoking or environmental stuff like overcrowding and poor ventilation, and you've basically created the perfect storm for TB to just take hold and thrive.
All right, we've got the what, the who, and the how. So now it's time to play detective. How do we actually find the clues and nail down a definitive diagnosis for an active TB infection?
And this is the big question, right? Imagine you're the clinician. You've got a patient, you know their risk factors. So what are those specific red flags you're looking for? What are the telltale signs? The symptoms really show you that this disease has two different faces. On one side, you've got the direct attack on the lungs. We're talking that chronic cough, producing sputum, and sometimes, and this is really scary, coughing up blood. Then, on the other side, you have these whole body or constitutional symptoms. These are the signs that your body is fighting a massive war inside: the fevers, the night sweats, and that slow wasting away. But look, a suspicion is just that, a suspicion. It's not a diagnosis. So the million-dollar question is, how do we go from just thinking it's TB to having concrete proof? Okay, let's look at the main tools in our diagnostic toolbox. First up is sputum microscopy. It's fast, it's your first look. Then you've got GeneXpert, which is a total game changer. It's also super fast, we're talking hours, and it does two amazing things. It confirms you have TB, and it checks for resistance to rifampicin, which is one of our most critical drugs. And finally, you have the culture. This is the gold standard. Now, it's slow, it can take weeks, but it's the ultimate proof because you're literally growing the live bacteria in the lab. Now, beyond the lab, we need to get a picture of what's happening. And for that, we turn to the chest X-ray. See, this bacteria loves oxygen, so it often sets up shop in the upper parts of the lungs. As the disease gets worse, it can actually eat away at the lung tissue, creating these hollow spaces, or cavities, that you can see on the film. You might also spot swollen lymph nodes right in the center of the chest, or even a miliary pattern, which looks like tiny little seeds scattered everywhere. That's a sign it's spreading. So, the diagnosis is confirmed. Now the real fight begins. And believe me, this isn't a sprint. It's a long, structured battle that demands total commitment from everyone involved, the patient and the entire healthcare system. The standard treatment is basically a 6-month marathon, and it's broken into 2 phases. For the first 2 months, you're in the intensive phase. We hit the bacteria hard with a 4-drug cocktail. You can remember it with the mnemonic RHZE. After that, you move into the continuation phase for another 4 months. Here, we back off to just 2 drugs, and the goal is to hunt down and wipe out any of those stubborn bacteria that managed to survive the first round.
Okay, listen up, because this next part is absolutely critical. The number one threat in this whole fight is the bacteria becoming resistant to our drugs. To stop that from happening, the golden rule is something called directly observed therapy, or DOT. And it's exactly what it sounds like. A healthcare worker literally watches the patient take their pills every single day. It might sound extreme, but it's the best way to guarantee they're taking the medicine and to prevent resistance. Yeah, it's that important.
Of course, you can't use drugs this powerful without expecting some side effects, so it's really crucial to know what to watch out for. For example, rifampicin famously turns your urine and tears orange. It's not dangerous, but you definitely want to give patients a heads up. Isoniazid can cause nerve damage, which is why we give it with vitamin B6 to protect the nerves. Ethambutol can mess with your vision, so regular eye exams are a must. And you probably noticed the common theme here, right? A lot of these can be tough on the liver. But the fight isn't always won. So what happens when treatment fails? What are the consequences? And maybe the most important question of all, how do we break this cycle of infection for good? Yeah, the fallout from failed treatment is just devastating. The lungs can be left permanently scarred, totally destroyed. The infection can escape the lungs and travel to the brain, causing something like TB meningitis. But the outcome we fear the most, that's multi-drug resistant TB. This is a strain that just laughs at our best drugs, making treatment ridiculously difficult, long, and expensive. And that brings us to what's arguably the most important topic of all, prevention. How do we stop this from happening in the first place? Look, there's no single magic bullet here. It's all about a multi-layered defense strategy. It all starts with finding and treating cases as early as possible to cut off transmission. Then you have basic public health stuff, good ventilation, the BCG vaccine for kids, and of course in hospitals it means super strict infection control. We're talking N95 masks, special isolation rooms, the works. So I want to leave you with this one big question. Think about it. TB is curable. It's preventable. We have the science. We have the tools. We know how to find it, how to treat it, and how to stop it. And yet, it is still one of the world's top infectious killers. Why? That question forces us to look past the textbooks and the biology and start thinking about the bigger picture, the social and economic issues that let this ancient enemy hang on. And that's our deep dive into tuberculosis, all based on the fantastic high-yield notes from DR Kate Premium Revisions. Thanks so much for tuning in.